today we're going to talk about some more dermal biopsies and some procedures we do in dermatology. Here's our lecture objectives. I'll let you go through those. Is that the second I'm getting older? To what?
Oh, slideshow.
Thanks, Olivia.
Better? And it's still small, but
Still small, but better. Okay, why do we get biopsies? They're a great way to get additional information. You can get a lot of historical information and clinical information, but sometimes you just need more to get to a diagnosis. And you can either have a pretty good suspicion of what that diagnosis is and you get confirmation, or you really don't have a clue and you have several differential ideas, and this will help you to figure it out. Skin biopsies are relatively very easy to perform, and there's a lot of skin out there, so it's easy to get to with a few exceptions. Okay, so we have various techniques of obtaining biopsies. We have curette, snip, scissor, shave, punch, incisional or a wedge biopsy, and our excisional biopsy, or just an excision. So we'll talk about these. A curette is when a lesion is very superficial and it detaches away from the epidermis very easily. I think I mentioned I use these for removing molluscum. I do that quite a bit. Another thing you tend to use that for are seborrheic keratoses. Have you guys talked about seborrheic keratoses? A little bit. They're those brown, kind of stuck on, verrucous kind of looking, completely benign. Some people are honestly covered in them, and that's one way you can get rid of it. And you just, a curette is this kind of round shaped tool that has a really sharp edge, and you just kind of scrape that away. Now occasionally I will use it as my way to get a biopsy. For instance, if I happen to biopsy a molluscum, which I don't usually do just because, clinically you know what they are. Or if, say, I have a lesion here that I feel quite strongly it is a basal cell, and I tell the patient, they're 90 years old and live out in Timbuktu, and they really don't have the time or the ability to get the biopsy today, come back in 2 weeks later. So what I'll do is I'll say, okay, let me just scrape a little bit of this off, get a biopsy, we'll send it in just to verify that I was correct, but I'll go ahead and treat it today with an electrodesiccation and curettage, or ED&C. So my first swipe with my curette for the ED&C, I'll put in the container and send that off and just verify that that's what it is. Typically, you don't use this as a real biopsy or way to get a biopsy, because it's pretty, you kind of tear that specimen up quite a bit. It's not ideal. Snip scissor is really good for when you have things that are really sticking up off the skin. A skin tag, filiform wart. Have you heard of that term, a filiform wart? It's these warts that have just these little finger-like projections. Things like that. Sometimes a person will want you to anesthetize the base before you snip it off. Some are just like, go for it, because it's kind of 6 of one, half dozen of the other. The numbing medicine can hurt every bit as bad as that quick little snip sometimes. So, shave biopsy. This is the most common way we get a biopsy. And this is when you're going to get something that's not just up on top of the skin, but down into the dermis. Probably mid to lower dermis. Sometimes you will do what we call a saucerization technique, shave biopsy, where you really get a pretty deep, but then that's really only down to the lower dermis. You're not really getting subcutaneous, okay? There's 2 methods to do that, and we'll kind of go through that later on. A punch, this is probably our next most common. Again, this is when you're wanting to get more of a full thickness of the skin. You basically get down to the subcutaneous tissue, the subcutaneous fat, but you really don't get much of that to sample. But you should get the full thickness. The exception might be like on the back where the dermis is really quite thick, and sometimes that punch just isn't even thick enough for that. But it's intended to get down through the full thickness of the skin. Sometimes we'll use a punch for a small, like a small pigmented mole that we might have concern about. I'll get a punch that's just a couple of millimeters wider than the actual lesion itself, and I'll try to remove the whole shebang, and you go down deep enough. You know, if you just shave that, if that pigment is pretty deep, you may leave some pigment there, and then it'll grow right back, or you'll have to go back in and do a second procedure. Punch, and there's varying ranges of size of punches, anywhere from a 2 millimeter punch to a 10 millimeter punch. I will use 2 millimeter punch sometimes on the face to minimize how much of a scar. Usually we use 3 or 4. I will use a 10 millimeter punch or 8 millimeter punch when I'm using it to like open up the skin over a epidermal cyst, and you want just a small opening, and from that you kind of dig in there and get out the entire sac of the cyst, but with that just a 1 centimeter wide opening. Okay, incisional biopsy or a wedge biopsy is basically when you have a very large lesion or if you suspect it's very deep. And your intent is not to try to get the entire lesion. You just want to get an adequate amount of specimen to get some good histopathologic results. Again, with this, you're going to do more of a wedge, kind of a triangle. We'll look at this. But again, you're not intending to get in the entire lesion or clear margins or anything like that. You just want an adequate sampling. And again, that you're going to get down into the subcutaneous tissue. So, okay, an excisional biopsy is basically just an incision. Sometimes I would use that, say, I've got a questionable looking mole on a young lady's face. Well, I don't particularly want to do a shave on that, and it's big enough to where I don't really want to do a punch, because sometimes when you do the larger punches you do, they're perfectly round, and the larger they are, when you pull that skin back together, they're going to pucker up. So I don't like to leave these little dog ears, you know, on the face of a young woman. So I will maybe, either myself, I don't like to do much on the face, but I'll refer and say, let's just do an excisional biopsy. Just get rid of the whole thing while we're seeing if it's okay or not. So with excisional biopsy, you are trying to get the entire lesion, clear margins, get down to the subcutaneous tissue, so that they can see how deep this lesion goes as well, especially your melanomas. You always want to see how deep things go. Or deeper inflammatory things like erythema nodosum. Sometimes there are lupus profundus, which occurs down in the subcutaneous fat, or involves that as well, and so you want to get a sampling from there as well. This, though, obviously takes a lot more time than a simple little shave, because you usually have to do some subcutaneous stitching as well as stitching up above. Any questions on those techniques? All righty. So when we're going to do a biopsy and leave a scar behind, we want to make sure we get the best possible sampling we can. When we're looking at tumors, you know, potential skin cancer, a lot of these skin cancers, like your basal cells and your squames, will oftentimes get a lot of thick crust on them, or thick scale. You don't want to just get that superficial sampling of just the scale, because that's all the pathologist is going to see. So you need to make sure you get a deep enough, adequate specimen so that they can actually see if there's cancer there. Trying to get through the deepest or thickest part, I think, to me, is just making sure you get down past any crust or scale, so that they can see a good true sampling. Inflammatory processes, oftentimes when you see somebody, a lot of rashes are very, very itchy or pruritic, so they've been, digging at themselves for weeks to months before they come in and you see them, and trying to find a good sample, it can be somewhat challenging. So I oftentimes will ask the patient, you're gonna be asking, where did all this start? And where did it spread onto your body? Is there one that came up more recently? What would you say is the most recent, newest spot on your body? And they may be able to point to one. And that is a good thing to do. Another thing is if you can just feel, if there's more induration, more redness, just a better sample. Again, rather than one that's real scratched up and crusted up or thickened up from just chronic scratching or lichenification, we call that. Any blister, ulcer, or necrotic area, like I talked about yesterday, you want to try to get a sampling of the blister as well as going through that normal tissue. There's an ulcer called pyogenic gangrenosum that is an ulcer that you tend to get associated with those who have Crohn's disease. And so, again, that's a good sample where you don't want to get smack in the middle of it, but rather the leading edge and some of the normal tissue. There's no real, absolute contraindications to biopsying, but there's a few things you want to keep in the back of your head before you just jump into biopsying. Lesions on the temple. You've got a real superficial, big vessel there that I would not want to mess with, get into trouble with. A pulsatile mass, obviously you got that's a blood flow issue. It could be a bloody mess if you open that up. Cystic midline masses. There are several cystic lesions. There's something called a dermoid cyst. You tend to see more in kids or young people. It can be on the outer part usually up around the eyebrow. If it's more towards the middle, the glabellar region, or if you have a cystic type lesion down, midline of the back or midline of the neck. These can be things that have connection to something deeper, either, below the skull, the nervous system. Here there's a thyroglossal duct that can sometimes be left over from development, and to cut that out, it can sometimes be attached to that hyphoid bone, and I don't want to get myself into that, so I might. Just oftentimes you need to do some other, like an MRI or something like that, to see if there's any communication with these things below what you are seeing. Informed consent. You always need to educate your patient on what you're going to do, why you're doing it, what are the potential complications. And with these simple things, it's mainly bleeding and infection and scarring, disfigurement, sometimes nerve damage. That wasn't on there. Bleeding, again, is not usually a big risk, especially with the smaller just biopsies. Infection is very, very minimal, the risk for that. Now, I don't usually prescribe oral or even topical antibiotics really to anybody unless if it's in a high-risk part of the body, like the groin, the armpit. Lower legs, distal legs, I do tend to, especially in an older person who has a lot of chronic swelling and stasis, venous stasis changes, just because that's going to be so slow to heal. And I think it's just best to cover for 5-10 day course of that, or topical antibiotic anyway. You learn. I'm simply amazed at the number of people that don't realize that if you cut the skin and get a biopsy or take a mole out, that you're going to leave a scar behind. I mean, to me that just seemed like so common sense, but I have had so many people say, oh, that's gonna leave a scar. Yeah, pretty much. So anyhow,
If they ever watch Nip Tuck, that show that used to be on FX. they
I have
watch the
heard of
plastic
that.
Surgeons. Like these women would fall through glass doors and like be all cut up, and then the next day they have no scars.
oh,
Maybe they
of
watched
course.
that show. That's why they got that they don't get
Drama,
scars.
drama,
You're
drama.
right.
Yeah, in the movies you can have
Right.
scars. But in reality, because you will get a lot of young people and their moms saying, I want every mole removed from her body or his body or whatever, and you're just like, well, every time I remove a mole, I've got to replace it with a scar, so which would you prefer? You know, I do, I say, I want to make sure that if we take something off, that you're not going to dislike more what we give you in place of it than what you've got there right now, so. All right, anesthesia, with the exception of maybe that snip excision, you're going to use anesthesia. We usually use lidocaine, either 1 or 2%. I have always used 1%, and we add epinephrine really all the time, or lidocaine with epinephrine. I know there's always that scare of, oh, don't use that on the nose or on digits or things like that. I think they're thinking now it has not so much to do the reaction of the epinephrine, but the volume of that maybe mixed with the epinephrine, that it's just so much compression and tightness that you can damage some of the blood vessels. But we use it always. You're going to use it on the face. The scalp is the bloodiest thing in the world, it seems like anyway. The onset of lidocaine is very, very rapid as far as the anesthetic properties, and people will be pretty freaked out because I'll, numb something up and I'll grab the thing and they're like, oh, hold up, is that numb yet? And I'm like, yes, it takes pretty much immediate effect. As far as the vasoconstrictive properties of your epinephrine, the full potential can take 5 to 15 minutes or so. So if you have the time, if you have another patient that you can go see real quick, and you're working on the scalp, which can be so vascular, maybe inject with that, step out for about 15 minutes or so, and then come back and you may have less bleeding issues. Okay, you know that the epinephrine can affect receptors on the heart, so it can cause tachycardia and just people feeling kind of uneasy. So, and people will say that, and so just reassure them that that's kind of a normal thing. That you do want to be careful with those that have severe, out of control hyperthyroid issues, as well as pheochromocytoma. About the only time I don't use epinephrine in something is when I've had one patient who says she just cannot use it, and then with pregnancy, if you're getting a biopsy on a pregnant or lactating gal. Okay, some people will say, I am allergic to the canes. I did have one person who. So you're like, okay, now what do I do? Lidocaine is in the amide group, and you don't need to know all this, but there are other groups of anesthetics, such as in this ester group, such as those others. So if they know that it's, one group versus the other, you can certainly use this other group. If they just say all canes, whether that's really actually the truth or not, I found out, I didn't even know this until I was preparing for this lecture, but sometimes the 1% diphenhydramine, which is just Benadryl, can act as an anesthetic for a short period of time. And it described how you make a 1% diphenhydramine solution. So that might just be something to kind of keep in the back of your head for future use, if you have this. I had one gal who came in saying that she was allergic to all canes and she wanted something removed, and I'm like, okay, what do I do now? And she, but thank God, she had testing done allergy testing done, and she knew that there were a couple that she could tolerate. So I had to order that specifically for her and said, come on back, we'll call you when we have that in.
Hey, Amy, is the one that they spray on it, is that tetracaine? The,
Ethyl chloride?
Yeah.
Yeah.
okay.
Did I not, oh yeah.
Well, I just couldn't remember, I was like trying to think of what the,
Ethyl chloride is what I think it's called. It's just a
Okay.
cold spray that kind of superficially numbs. I have a
we had a
case.
one patient too that said he was allergic to all the canes. And I was like, well, we got a
That
biopsy.
should be fine, yeah.
I think we ended up, since we couldn't find anything like hers, we ended up having him taken to the OR
Oh,
to
really?
biopsy.
Okay.
Because we had no other options in our clinic.
Yeah, I know, you're stuck sometimes. Ways that you can, lidocaine is an acidic product, so it burns pretty good. Have any of you guys had it injected? Yeah, it bites pretty good. It's because it's acidic. So ways that you can kind of minimize this is to slow that infusion down, or the injection of that into the skin, and that does help. Using a smaller bore needle, 30 gauge, the larger the number, the smaller the size of the bore of the needle. So it's kind of inverse relationship. Typically, you will draw up out of the bottle with like an 18 gauge, a pretty wide one, and then take that off and switch it for a smaller one, just to be nice. And then you, although I've thought about using that 18 gauge timer too, but a nasty patient. Okay, you can buffer with sodium bicarb. And this can help a lot. It really does help take the sting out. I will do this more with kiddos when I'm having to get a biopsy from them. The downside to this, and we didn't find this out until recently, they have like a regular bottle like what you would see your lidocaine in. Yeah, something like this. It's like that size. And it's intended for a single use. So what a waste of medicine. Because we used to, till we kind of got in trouble, we used to just, draw out a little bit and leave it up there until the next one, wipe it off, and how regulatory stuff gets involved, and so we had to stop that. But we do keep them handy, and then we just chunk them after that. Pinching or tapping the site. Sometimes trying to, divert their attention from something. Ice and firm pressure. In fact, I went to a kind of a training thing. I tend to suffer with hyperhidrosis, excessive sweating. And so I went down with another gal for a training for, Botox injections. You can do Botox in the armpits, but they were doing training into the palms and the soles. And talk about painful in your palms and soles. And you have to do them like a centimeter apart. So like my palm, and I have very small hands, would take about 100 injections. Yeah, isn't that fun? And how they taught us was they would make these little cylindrical ice cubes, and we would push real hard for like 7 seconds, release, and then inject your Botox. And it helped a lot, according to the patients. I wasn't brave enough to be on the receiving end of that, but yeah. So it's that temperature, pain, pressure, nerve thing. The ethyl chloride is kind of another thing. It's a cold spray. I don't use that a lot unless I just don't think it helps a whole bunch. Or the Emla. Emla is kind of a topical lidocaine. It really has to sit on the skin for 30 minutes to an hour under occlusion to really do anything. And maybe I'm callous, but I just as soon get her done. And because usually once, for kiddos I'm talking about, most adults don't require this, but kiddos, usually once you're done and they're in their mom's or dad's arms again, they're completely fine. They're giving me the evil eye, but that's okay as long as, it's done. But that is an option, but it does have to stay on the skin for a pretty long time. Okay, so here are pictures of subcutaneous infiltration. as well as dermal infiltration. When you inject into the dermis, it's gonna feel, you're gonna feel a little bit more pressure to push that in. And it's gonna lift that skin, you're gonna form a wheal. And most of the time when you're getting biopsies, you're gonna wanna do that. Subcutaneous, when you're doing a wider excision, you're gonna do kind of a combination of the two. You're gonna do more dermal right around, but then get some deeper subcutaneous so that, because you're gonna be cutting deeper down. Hemostasis, we use there are a number of different ways to get the bleeding to stop. In my clinic, we use mainly aluminum chloride and the ferrous sulfate, the 10% ferrous sulfate. There's also a Moncel solution, that's a ferric subsulfate. A couple of things to know, the aluminum chloride I don't think is as, well, I know it's not as effective, but the other two, because there's iron in them, can stain the skin. So I would generally try to use more of the aluminum chloride with biopsies on the face, and then use the others to other parts of the body. You can use cautery. At previous clinic, we didn't even use the chemicals, we just cauterized everything, but that kind of encourages more scarring. Pressure, you can always use pressure. They have sponges, gel foam, and you might use that if you're doing a punch and not putting a suture in. That just kind of packs that and helps to form your body to form a clot. This quick relief powder, I have no idea what that is. I have never used it. And in surgery, they're using, you know, like this super glue for skin sort of stuff, but we're doing that. Okay, so here's some examples or diagrams of the different biopsies. That is a curette biopsy. Again, just kind of scraping, doesn't go deep at all, just kind of in that epidermis. Snip scissor. Again, that's a skin tag, it looks like, or a fleshy mole. You just grab your forceps or your pickups, and get the top of it, lift it up, and then down at the base, you'd be using smaller scissors than that, and then just, you know, release it. It's gonna bleed, but then you can put some of that ferric chloride or whatever. Oops. All right, shave biopsy. Again, you want to anesthetize to produce a wheal. That just lifts it up, easier for you to get to. Basically what you're going to do is you're going to stabilize that skin lesion between your thumb and your forefinger. Some people will use a 15 blade. Let me kind of show you what the blade, now pardon my drawing abilities. That's more of like a 15 blade. That is more of a 10 blade. And your 11 blade is like that.
What are the numbers specifically referring to?
They just number them, I don't know. Nothing that I know of. They just number them for what shape they are and the size they are. So this one has a much smaller cutting space. You're going to use, well, probably for your shave biopsies. I tend to use that when I am doing excision from where the dermis is not as thick. The arm, pretty much anywhere, maybe except the back. The back has really thick dermis, so I'm going to use a 10 blade because you need that thicker blade to get through that dermis. And then this I use more for maybe the wedge we'll talk about, or I will even use that to IND. You know, if you have a big abscess and you just want to open something up, or get out a a cyst or something like that. Or a lipoma, I'd use that. I'll just kind of open a linear opening, pop out that lipoma, and then bring it back together with some stitches. Okay, so 15 blade, one of the smaller ones, parallel to the skin, and you just kind of use a smooth sweeping movement to just kind of swipe it off, rather than a sawing motion. If you can, as you are kind of swiping that through, you might just with your finger try to steady that specimen, that piece of skin, so that it's not sliding around as you're cutting through, because that has happened to me more on the blade, where if you're not stabilizing that, you just kind of keep cutting more skin, and you don't want to do that. Now, what I have used more is not so much the 15 blade, but a straight edge razor, double edge or single edge sword, and that's primarily what you guys are going to be working with. And you will just hold it between your thumb and forefinger, just kind of bend it up, and you can bend it up pretty, concave or less so, depending upon how deep of a piece of skin you want. And with that, you're just kind of doing a rocking motion. One thing I do like to mention is we talked about infiltrating that anesthetic so you develop a wheal. One thing you have to be careful about is when you are doing that and getting a biopsy, like on an already concave piece of or area of your body, like the cheek, it's already concave, and then you're making it even more concave with pushing in your anesthetic, and then by even leveling it off, or if you really get a little bit of a scoop, boy, when that anesthetic wears out, you're really going to have an indentation there. So you just have to, that takes practice, but be careful about that. Okay, I think we covered all that. And again, as you're coming through with the biopsy, if you can stabilize with that or the other one so that you're not just continuing to cut skin. All right, here's a sample with the 15, that's what a 15 blade looks like, see, compared to my measly old drawing. So again, very superficial. I would say the blade, or the straight edge razor, you can get much easier down into the dermis than that. I rarely have I used a 15 blade to get a shape biopsy. It's usually always this. That is what it looks like with the straight edge razor. Some people prefer the double edge. I've always preferred the single edge. All right, a punch. So with a punch, and do we have a sample of a punch? Yeah.
Yeah, there's 3 and 5, and there might be a few 4s in there.
So with a punch, you want to figure out which way the skin lines are running before you do anything. All right, so determine the direction of the skin tension lines. You're going to put the numbing medicine in there. You want to choose what size of punch you need. This happens to be a 4mm punch. Again, you're going to stabilize with, and this is a punch. A punch is just basically a cylindrical knife. It just has an opening. So you get a little cylinder of skin, basically. Again, you're going to stabilize, but what's important here is you want to apply some outward pressure perpendicular to the skin tension lines. Okay, so for instance, here are your skin lines. You want to stretch out this way as you are getting your specimen, because when you're stretching and when you pulled it in with a perfectly round biopsy, if you pull that and you do that, when that comes together, it's gonna be a little bit more of an oval rather than a perfect circle. And then you will better be able to bring that skin, approximate those edges more neatly. You always want to take this perpendicular to the skin, not angled. Typically, they call this down at the base of the metal part, they call that the hub. A lot of times you're gonna push it down to the hub and you will be able to feel there's kind of a give when you get through the dermis and into the subcutaneous fat. However, there are times when the dermis is very thin, such as on the hands, such as on the face, and you won't need, and I would maybe recommend not going down to the hub, because I have heard somebody, hitting a pretty good sized vessel with that. It wasn't me, I promise, I would tell you. But you can usually, even when the dermis is thinner, you can usually kind of tell when it goes through. And they say not to lift it up and redo that, but if I've done that before just to see if I'm all the way through. Oh, sorry. Then, once you get that, then you're going to lift carefully with your pickups, carefully lift that up. You don't want to crunch that piece of tissue, just lift it up carefully, and you will see the subcutaneous fat, and then cut, get a little bit of that fat, and then put that in your specimen bottle. Okay. This is a picture of the skin tension lines, just good, handy to have for future reference. And that is what the punch. Typically, I have always put a suture in, sometimes 2 or 3 sutures if it's a 10 millimeter punch, usually just 1 suture if it's a 3 millimeter punch. Some people don't put in sutures and they'll fill it with that gel stuff and just let it heal by secondary intent. I think it looks better if you can bring it back together. But when you're using suture, you shouldn't need to use any of the topical aluminum chloride, ferric sulfate, or whatever those were. Okay, an incisional or wedge biopsy, like we talked about, we want this to go deep, get down into that subcutaneous fat, and this, you may either do just a smaller elliptical lesion or just get kind of a triangular, use one of these and do a bump, 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 take that out, get down and then take that out, plus or minus sutures. I've never done that, but an incisional. And there it goes. You can see the outer border of that, where that lesion looks much larger than what he's just kind of cutting out in the middle of it. So an excision or excisional biopsy. This is when we're trying to get the entire lesion and deep enough down into the subcutaneous plane. Typically, you're always going to use sutures. Again, here you're going to determine the direction of the skin tension lines, and the length of your ellipse is going to follow the skin lines, okay? Not go against them. So you will find here's your lesion. Typically, how much clear border you want depends upon what you're cutting out. We're not going to get into that. For our purposes, we're going to say 2 to 3 millimeters. So say here's 2 to 3 millimeters out, from each side. This is the size of area I want to cut out. So from there, I'm going to cut or draw my my ellipse, and your ellipse is always gonna be 3 times as long as it is wide, generally speaking, at this stage of the game. You know, a lot of doctors will do a 2-to-1 ratio, but as you pull all of that out and you bring that back together, that's gonna lay nice and smooth so you don't have puckering on either end. All right, when you are using your, excuse me, bless you, scalpel, typically, again, either one of these you're gonna be using, not that one. You take the pointy edge, perpendicular here, and just kind of pierce the skin, and then as you're coming down, you're gonna use more of the bigger blade. And you can put decent pressure. Again, you're gonna feel when you get through that subcutaneous tissue. And you're trucking along here. As you are trucking along here, you're gonna try to keep the edge of that as straight as you can without, you know, curving it in or out. And then as you're coming back around here, you're gonna curve that up, curve the belly up so that you end with the tip, okay? Do that on the same. You wanna try not to overcut it and then make those cuts out there. Once you get that and you can see you're down to the subcutaneous, then if it's not completely cut here, you're gonna get your scissors, and sometimes I'll just cut straight down to release it there, or use your blade, whichever. You're gonna lift that up, and then either with scissors or your blade, you're just gonna kinda, you know, cut that down at the subcutaneous level. You wanna try not to, you know, get it real shallow and then real deep in the center. You wanna try to keep it as consistent as you can. Okay, I think I talked about all of that. I may even talk about all of that. Oh, once you get that out, the main area out, you're gonna have some bleeding in here, some, you know, subcutaneous bleeding. That's when you're gonna get your bifurcator and kind of zap some of those subcutaneous fat. Now, you don't want to zap, the dermis is gonna bleed a lot, but you don't wanna zap those, because those you want to grow back together. But anywhere in that subcutaneous fat is fine to kind of stop those bleedings, those small vessels. Sometimes if the larger excision that you have, you may need to do undermining. Undermining is when you have, you know, you would pick this side up, and again, you don't want to pinch real hard because you don't want to damage that dermis there. You go usually at the level of the dermis and the subcutaneous fat, and then you put your closed scissors in there and open them up. You probably did that in anatomy. So, same thing, same process. Do that on each side. That is really good to help the tension. If, say you've got a tight back skin and you're trying to pull those together, that really, without undermining it, really puts a lot of tension on those sutures up on top of the skin. Okay, sutures, we have absorbable and non-absorbable. Absorbable comes from a mammalian gut, and then they have synthetic forms such as Vicryl, Dexon, and PDS. And then you have your, absorbable are usually always down underneath the skin that will absorb. You don't have to take those out at a later date. The non-absorbable are used for the skin closure up on top. And those include silk, nylon, or Ethlon, and Prolene. They have various sizes. The bigger the number, again, kind of like the needle bores, the bigger the number, the smaller the size of the suture material, and it's not as strong. So a 3/0 suture is thicker and much stronger. So I'm gonna use a 3-0 on the back, maybe a 4-0 on other parts of the body, on the face, 5 or 6-0. So, would you agree with that? Did you guys do different?
Well, when I used it in the office, we mainly just had the 3-0 nylons, because if I took a biopsy on something out here that's an mine are all big masses. So I basically never really stitched it back up. I would just biopsy it and silver nitrate it. Or like on the tongue, I would generally silver nitrate it and pressure. And so I rarely used the
Suture.
sutures unless for some reason someone comes in. I had this happen quite a bit. If they had recon and they had a flap on their chin, a lady once had a Z-plasty of a squamous cell on her lip. She came in and she had dementia, and she pretty much just pulled out all her stitches. So you could see right through to her gums and her teeth from her lip. And I had to throw 1,000 stitches in and try to close it.
That was fun.
Yeah, but I didn't really use any of the dissolvable ones. I used mainly just Rego.
Okay, but everybody kind of, the more you do it, the more you kind of figure out what you like. They have different needle sizes, how, big they are. For the back, you generally like a bigger needle versus a little needle, just so you can get more of that tissue with every bite, that sort of thing, but I'm not going all over that. So this is what your angles at each is usually around 30 degrees. You don't have to get your protractor out or anything for that. But. So skin tension lines, the length of the incision or ellipse will go along those tension lines with a 3-to-1 ratio, length versus width.
Were you saying to undermine underneath the skin that's going to remain?
Yeah.
Okay.
Yeah. And all that does is that just loosens that,
Right,
so then you
pulls
can
together.
shove it in
Okay,
easier.
that makes sense.
And then I think I've got one more on the sutures. Again, we talked a little bit about subcutaneous sutures, and then up top, on your left are subcutaneous tissues, and that's where you kind of go in on one side up high, come down low, and then go in low and come out high, or vice versa, actually. Did that wrong, I'm sorry. Down low, like that. And then you tie it, and then when you pull that up, you cut it so that all of that tissue or suture material is down below the skin. And that really helps to pull those, approximate those edges, and you don't have this open gaping area where blood can collect and things like that. And it helps reduce the tension up on the top, superficial sutures. When you're doing superficial skin sutures, again, what you're wanting to do is to go down at a 90-degree angle. Don't go in narrowly, but take a big bite from there. Some people will come in halfway through, re-needle, and then go, or you can just do it all in one. It depends on how much practice you've had. But you almost want more tissue down below than up here, and that helps to evert. That's what we want, is to slightly evert the wound edges so that they heal better. If you invert, which is what that second thing will do, it just takes longer to heal and it's an uglier scar.
On the one on the left, is the knot being tied down in the sub-Q?
Mm-hmm.
Okay.
Now, those are like, when I worked for my plastic surgeon, we do abdominoplasties. When he would do one side, he would do the deep abdominal, and he would hand tie. So he would do the deep ones, he'd finish one side, go back over, and then I would do just the, up a little bit higher, like I would do under the skin, and then I would also throw superficial ones as well. Because that belly, you really want to make sure it stays closed tight.
Yeah, I've never done
But yeah, those are thrown
deep
underneath
sutures.
the skin. And that's why when you guys get to capstone, you guys will learn how to do one-handed ties. Because you don't have much room down there. and you do one-handed ties down there.
Used to know how to do that, but I don't know how to do it now. Okay, any questions? Yes.
Okay.
We
Y'all will take a
will
break, I'm not gonna close the next meeting.
Why don't we take a little break?